Welcome to today's Public Health Ontario Rounds presentation on the challenges of tuberculosis management in Sioux Lookout area First Nations communities. My name is Andrea Saunders. I am a communicable diseases specialist here at Public Health Ontario, and I have the distinct pleasure of moderating today's session. And as moderator, I would also like to state that I do not have any conflicts of interest to disclose. Before we get started, I will be mentioning a few housekeeping items. We will be disabling the chat pod to limit any distractions during the presentation. However, if you have any questions during the session, please enter them in the Q&A pod at the bottom right-hand corner of your screen, and we will address them during the discussion period immediately following the presentation. If you experience any technical issues during the session, please email capacitybuilding@oahpp.ca. It is now my pleasure to introduce the speakers for today's presentation, Dr. Lloyd Douglas and Dr. Yoko Schreiber. Born and raised in Jamaica, Dr. Lloyd Douglas's interest in public health arose while studying medicine at the University of the West Indies. Since moving to Canada with his family, he has focused his intention to serve First Nations communities in preventive medicine and public health after completing his training at the Northern Ontario School of Medicine. Dr. Douglas is currently employed with the Thunder Bay District Health Unit and seconded to the Sioux Lookout First Nations Health Authority. He provides leadership and technical expertise for the implementation of approaches to community well-being, a First Nations-based and governed public health system for the people and communities in the Sioux Lookout First Nations Health Authority. He works, plays, and prays on the traditional territory of the Lac Sioux First Nation, signatory to Treaty 3, and walking with First Nations communities on their journey to good health has been his passion ever since. Dr. Yoko Schreiber completed her specialty and subspecialty training in internal medicine and infectious diseases at the University of Ottawa, followed by a Master's of Science in Epidemiology under the Clinician Investigator Program. After working for several years at the Ottawa Hospital and the University of Ottawa, she decided to move closer to the community she wished to serve and relocated to Sioux Lookout. She currently holds a position as an assistant professor at both the Northern Ontario School of Medicine and the University of Manitoba. She spends her time providing general infectious diseases clinical care in the Sioux Lookout region, as well as spending several weeks a year at the Winnipeg Health Sciences Centre. Her practice spans from clinical care to assisting with public health issues, which includes research, education, and involvement in national committee work, including Indigenous Services Canada's First Nations and Inuit Health Branch and the Association of Medical Microbiology and Infectious Diseases Canada. In all, she considers herself to be the luckiest infectious disease physician in the world, being able to practice in a setting where it is needed, surrounded by lakes and outdoor opportunities in Ontario's Sunset Country, on the traditional lands of the Anishinaabe peoples. And with that, I will now hand things over to Dr. Douglas to begin their presentation.
Thank you, Andrea, and good day, everyone. My name is Lloyd Douglas, and I am happy to be here with you today, also with Dr. Yoko Schreiber. And also we have a distinguished guest. You'll hear from her later. She's from the community, Joan Ray, the health director for the Sand Lake First Nations. So today we'll be talking to you about the challenges of TB management in the Sioux Lookout area First Nations communities. The Sioux Lookout, next slide. The Sioux Lookout First Nations Health Authority acknowledges that it's situated on the traditional territory of Lac Sioux First Nation, signatory to Treaty Number 3 and the Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. Next slide. Before we begin, this presentation was created by us, Dr. Schreiber, myself, and also Joan will be speaking, and it will be shared on the PHO website, and further statements can be seen here. Next slide. In addition, we have disclosures for Dr. Schreiber and myself that can be seen on the screen. Next slide. Some aspects of this presentation may be, difficult, as there are the images and mention of residential schools, assimilation, ongoing harm, intergenerational trauma, and we acknowledge that this may be a difficult topic for some individuals on the call. So just wanted to remind everyone that this presentation is intended for advocacy purposes and to acknowledge the impacts, you know, over the years of contact and what First Nations have been going through. And we respect and honor all First Nations communities. And if there's any First Nation individual that's experiencing any pain or distress as a result of this presentation, there's a number that you can contact. You can call this line, the Indian Residential School Crisis Survivors line. It's a 24-hour crisis line at 1-800-721-0066. There's another line at 1-866-925-44194 for immediate support. And please do take the time to take care of yourselves. And if you're triggered, please seek healing practices that you're comfortable with, and also, get in touch with your elders or your loved ones. Next slide. So we hope that after this presentation, in terms of the learning objectives, we hope that you will understand how historical, contextual, social, cultural factors and the inadequate access to the healthcare system have negatively impacted TB management for Sioux Lookout Area First Nations. We hope that you'll understand the challenges of coordinating the management of TB care for individuals diagnosed with active TB and LTBI in the Sioux Lookout area, understand the compounding effects of the COVID-19 pandemic on TB management in the Sioux Lookout Area First Nations, and learn about some of the innovations in TB care in the Sioux Lookout area. Next slide. To understand the challenges of TB in the Sioux Lookout Area First Nations, we must understand the history of TB in Canada and the Sioux Lookout area. TB was introduced to Indigenous communities in the 1600s by the explorers from Europe. And by the early 1870s, TB was still relatively rare among the Indigenous population, especially of the plains of Western Canada. But within a few years, the situation changed dramatically. By the early 1880s, TB was widely recognized to be the primary cause of morbidity and mortality among First Nations populations. The explosion of the disease was caused by sudden ecological, economic, and also changes with regards to the politics at the time in the West. And this was primarily the result of the imposition of the Canadian Dominion. By the forced removal of the autonomy of First Nations and also their important food resource, First Nations of the West were left open to the impacts of a new disease. And within years of all of this happening, and also the treaties on the plains, TB, a chronic infectious disease that thrives on disruption and human privation, had established itself as the dominant threat to the health of the First Nations population of the region. Next slide. So as early as the 1830s, the residential school systems were established to remove children from their First Nations communities with the aim of assimilating them. Prior to this point, churches had built schools for Indigenous children since the 1600s. But in 1907, the chief medical officer of the Department of Indian Affairs, and some may hear of this gentleman, Peter Henderson Bryce, identified schools as an ideal vector for TB transmission, going as far as to say, it was almost as if the prime conditions for the outbreak of epidemics had been deliberately created. It is well established that social terms of health, including malnutrition, overcrowding, and poor ventilation, contribute to the development and spread of TB. And these conditions were common in the residential schools. Bryce found that TB death rates were far higher in residential schools than among children in the general Canadian population. In southern Alberta alone, he found that 28% of residential school children died with TB as the most common cause of death. According to the Canadian Public Health Association, TB death rates in First Nations communities in the 1930s and 40s were 700 per 100,000, some of the highest ever recorded in a human population. But in residential schools, they were astronomical, at about 8,000 per 100,000 children. Next slide. Now let's talk about TB in the Sioux Lookout Area First Nations. The first hospital was built in Sioux Lookout in 1921. And by the 1940s, TB in the surrounding First Nations communities reached epidemic levels. In 1949, the federal government built and operated a sanitarium for individuals living with TB from northern remote First Nations communities. This was later converted into the Sioux Lookout Indian Hospital, which became known in the 1970s as the Sioux Lookout Zone Hospital. This was an example of the historical trauma First Nation people experienced of prolonged confinement in TB hospitals, hundreds of kilometers away from their families and communities in the region. Of note, the Sioux Lookout Zone Hospital was at a separate location from the first hospital in the relatively small town of Sioux Lookout. And by 1951, a new Sioux Lookout General Hospital with 40 beds and vastly improved facilities opened for the citizens of Sioux Lookout. This was a significant indicator of the differences among patient care between Sioux Lookout area First Nations and Sioux Lookout citizens. It also served as a reminder of the federal government's responsibility for improving healthcare for First Nations. Fortunately, Sioux Lookout has an amalgamated hospital since 2010, a step in the right direction. Next slide. In January 1988, to draw attention to years of worsening healthcare and deteriorating relations between First Nation communities and the Medical Services Branch of Health and Welfare Canada, 5 men from Sandy Lake First Nation went on a hunger strike. The First Nations leaders and the federal government committed to improve health services, and the 2-day hunger strike ended. Next slide. This led to the creation of the Scott McCain-Bain Health Panel that reviewed the state of healthcare in the Northern First Nations communities. The From Here to There Steps Along the Way report was presented to the Sioux Lookout Zone chiefs in March 1989. Of the report recommendations, the chiefs accepted only one: the development of an Aboriginal Health Authority. This health authority is known today as the Sioux Lookout First Nations Health Authority. SLFNA works under the direction of First Nations leadership in accordance with its goals of self-government and self-determination. SLFNA now serves 31 First Nations in the area, providing a variety of health services. Next slide. Just as SLFNA was being established in 1990, the Sioux Lookout Tuberculosis Control Program was established in 1990 by the Medical Services Branch of Health Canada in response to the TB cluster outbreak and the recognized endemic status of TB in the Sioux Lookout area. In 1994, the First Nations and Inuit Health Branch Ontario Region TB program was established as part of the First Nations Tuberculosis Elimination Strategy by Health Canada. In 1997, 7 years after the establishment of SLFNA, the Sioux Lookout TB Control Program was placed under the administration and management of SLFNA. It has remained a centralized program. In February 2006, the Sioux Lookout area chiefs approved and mandated SLFNA to proceed with the implementation of the Anishinaabe Health Plan. An essential feature of the proposed system is the inclusion of a comprehensive public health program with TB control as a significant part of those mandatory services. In 2007, FNIB Ontario Region adopted the Ontario Ministry of Health and Long-Term Care TB Protocol 2006 as its TB management guidelines for TB on reserve. In 2008, FNIB Ontario TB program released policies to supplement the provincial protocol. Next slide. In 2010, the Chiefs in Assembly passed Resolution 1006, the implementation of a public health system which mandated SLFNA to develop an integrated model for public health for the communities. Through community engagement and working with tribal councils and community representatives, it was determined that the term public health was not the right term for the communities, and the name Approaches to Community Wellbeing was born. In 2016, the Chiefs in Assembly passed Resolution 1619, the implementation of Approaches to Community Wellbeing, which mandated SLFNA to move forward with the implementation of Approaches to Community Wellbeing, a First Nations-based and governed public health system. By 2017, the Preventing Infectious Diseases team that's under the healthy living component of ACW, formally took on the management of the TB control program. Next slide. So the Preventing Infectious Diseases team within ACW provides services to reduce and manage the incidence of TB in the Sioux Lookout area First Nations communities. Services include TB surveillance and maintaining and updating databases, contact tracing and case management, coordinating anti-TB drugs for treatment and prevention, educating and supporting individuals hospitalized with TB, providing disease case therapy and follow-up, supporting and facilitating directly observed therapy, health promotion, and TB prevention services. Next slide. Individuals with TB in the Sioux Lookout area First Nations are managed, however, by a fragmented health system. To establish the roles, responsibilities, and processes for the management of diseases of public health significance in Sioux Lookout area First Nations, a protocol was established in accordance with a memorandum of understanding between SLIFNA, the Northwestern Health Unit, the Thunder Bay District Health Unit, First Nations Inuit Health Branch, and the Ministry of Health. The protocol includes various activities, some more pertinent to TB management. And the protocol is also consistent with the historical relationship of the federal government in the provision of public health services to First Nations on reserve and the public health units with the MOH's responsibility to administer the Health Protection and Promotion Act. Next slide. So you can see that one individual with TB in our region, there are a number of partners who are involved in care. And this points to somewhat of that kind of fragmented system of care that we have. As a result of crossover responsibilities and jurisdictional ambiguities, there are several agencies, and like you can see, several agencies involved in TB management for Sioux Lookout area First Nations. To name a few, we have SLIFNA, we have the Sioux Lookout Minayawin Health Center, First Nations Inuit Health Branch, we have Northwestern Health Unit, Thunder Bay District Health Unit, we have the Physician Services, we have, thankfully, our ID specialists, we have the TB Regional Health Sciences Center, Winnipeg Health Sciences Center, and we also have workers at the community level. And this situation warrants unique challenges. Before I pass, the baton over to Dr. Schreiber, just looking at the active cases, active case count year to year since about 2017, you can see that there's an increase in numbers of active cases of TB in 2022. And over the years, LTBI cases have been relatively high, indicating a potential for reactivation of individual cases that may lead to outbreaks in the region. Dr. Yoko Schreiber will now review a few cases to underscore how historical and colonial issues impact the present-day management of TB. Over to you, Yoko.
Good morning, everyone. It is my pleasure to present here today about some of the experience of managing active TB in the Sioux Lookout region. So I will be drawing on a few cases from a cluster of cases over the last year. This is in terms of the history of the past few months. We had a first case in a community I diagnosed in September of 22, with the most recent case identified in May of 2023. So we're currently dealing with a cluster of 7 adult cases and 4 pediatric cases and 26 or more contacts. So what is really helpful with working with a TB team from SLIFNA is there's some incredible historical knowledge of past history that can help establish links between clusters of cases and seeing where contacts could have occurred and how cases link together. What we typically experience, we see some isolated TB cases over the years, but at times due to the proximity of housing and housing conditions and overcrowding, at times we do deal with a number of cases occurring in one community considering an outbreak. So from the most recent cluster over the past year, I'm going to talk about 5 cases, not in extensive detail, so as to respect confidentiality. So the first case was a smear positive pan-sensitive cavitary pulmonary TB case involving also the liver with multiple abscesses. A second case was cavitary pulmonary TB with presumed spinal TB, as well as a subcutaneous abscess. Another case, a smear negative culture positive pan-sensitive pulmonary and pleural TB diagnosed out of province. Another pan-sensitive cavitary TB with pulmonary empyema, and then a probable spinal TB without tissue diagnosis, also diagnosed out of province. Following these fairly active or very active cases that were quite readily diagnosed, through contact tracing, 3 additional cases were identified. And what I would like to highlight here is all these cases were contacts from the previous cases, and they were named as multiple contacts from 2 of the initial active cases. All 3 had converted to tuberculin skin test, were screened with a symptom inquiry. And just if you can see at the table, the symptom inquiry often was quite mild. One case had a cough for 2 months. The other one only endorsed some fatigue and low energy for 3 months, and as well as, again, fatigue and low energy for the last few months, with cough for the last week. 2 of these had a normal chest x-ray initially, and only on a second exposure, the third one had an abnormal chest x-ray the second time. However, we decided, because we knew there were such close household contacts from the active cases, we decided to send sputa, and they all turned out to be smear negative culture positive TB cases and are currently on treatment. I would just like to highlight that because I think knowledge of the housing situations and the nature of the contacts and the community structure and the relationship between these contacts and the active cases, it really helped us risk stratify them better, even though they didn't have significant symptoms, that our threshold for investigations was low, and therefore we were able to identify 3 more cases with active TB fairly early. In terms of some of the challenges faced with management of the active take cases, again, I will keep this discussion fairly broad, just again, to keep confidentiality of the patients. But some of the issues that we typically face in this outbreak, as well as over the past few years, I've been practicing Sioux Lookout now for 6 years, foremost is communication. As I mentioned, as 2 of the cases were diagnosed out of province. Again, sometimes the information of an active case gets fed to the health unit and then gets fed to the SLUFNA TB program. And at times we only get a cultural report of a positive sample or tissue diagnosis. And then it begins the track down on who is this patient, where is the patient, what are the clinical details, as especially when patients get diagnosed out of province, that does not necessarily get translated to the most responsible provider, the community, or to myself as a TB physician of the region. So there can be quite a few delays in terms of transfer of cares, as well as getting the details organized, as well as medications organized to make sure that they are in community when the patient gets discharged home. As Lloyd had mentioned, this LUFNA region covers 2 distinct provincial health units. So again, depending where the patient is located, when they travel, for example, from Sioux Lookout to Thunder Bay for some care, they actually travel to a different provincial health unit. Often what we experience is diagnostic delays in terms of diagnosis. One of the challenges in Sioux Lookout region is there's a lot of healthcare staff turnover. So when we do have physicians or nurses coming from Southern Ontario, they may not necessarily be aware of the endemic nature of TB in the region, and it may not be on the top of the differential. In one of the cases, who was diagnosed out of province, she was diagnosed postpartum, but in terms of symptom inquiry, it turns out she had weight loss of 50 pounds during pregnancy, as well as some night sweats. I've had other cases in the past who were diagnosed during pregnancy or after pregnancy, but after a delay of 12 months of poor weight gain or weight loss. And that has largely to do with some anchoring on often physicians or nurses or healthcare providers, just because there's so many competing diagnoses that can lead to weight loss or lack of weight gain during pregnancy. Food insecurity is prevalent in the communities. There's also quite a high rate of substance use disorder. And again, patients as well as healthcare providers often have to grapple with multiple diagnoses and competing conditions. So TB may not necessarily be on the forefront of their differential diagnosis. At times, patients are reluctant to come to Sioux Lookout for a diagnostic workup. One of the cases, that was the case. Sometimes that's because of legal ramifications. Some patients may have arrest warrants out in the community, out in different provinces or different towns that make them reluctant to come out. There's also still incredible stigma that people need to deal with. Again, many people have not forgotten what it is like to be in a sanatorium. Some people have memories of grandparents and parents who went to a TB sanatorium and have not returned home. So when TB is mentioned and workup of TB mentioned, people may be reluctant to come out and seek care as well as have the proper workup done. In terms of logistics, diagnostic delays, public health reports are sent by paper copy. They're not scanned into hospital EMR, and access in community EMR is sporadic. So if we do get a result, sometimes it's hard to even track that. An AFB sending from the community takes about a week to come back. And the culture is often take more than 8 weeks in terms of getting a report back from a final report in Thunder Bay Public Health Labs. So Sioux Lookout Minnehaha Health Center does provide a gene expert PCR for inpatients, but this is typically available for outpatients only on special requests. Again, due to the high turnover of frontline staff, ongoing education is needed, as there's always confusion on appropriate samples and requisitions to be sent. Most recently, we've had PCRs miraculously done on almost everyone because one requisition was photocopied and used over and over, just because, again, new people arrive and may not necessarily be familiar with the requisitions to be used. One challenge that I face personally in terms of providing follow-up care with patients is lack of phone. Many people do not have a phone. It's paper use cell phones, or the cell phone reception is not congruent necessarily in all communities. So often patients cannot be reached. In order to see patients in person, I need to fly them to Sioux Lookout, and that requires a non-inherited health benefits to arrange for travel and notify the patient of travel due to weather and sometimes miscommunications. That doesn't happen. Some people miss their follow-up appointments. It is also at times unclear who is able to order routine tests. There's not always a physician in community. So again, this can cause delays in terms of monitoring for blood work and any imaging that is required. Community DOT is incredibly resource intensive. Often patients may not have fixed housing or quite mobile, or they spend time in the bush. So the community DOT workers spend an incredible amount tracking down patients and ensuring they get the DOT. In terms of competing demands of patients' times, a lot of people have a lot of things going on in terms of that is affecting their healthcare. Some patients struggle with alcohol use disorder and substance use disorder. And again, more immediate needs can affect their adherence to DOT. Again, as you know, with alcohol use, it can affect interactions with the TB meds. And we've, one of the cases, developed alcoholic hepatitis and had to interrupt TB treatment for over a month until we could get the liver enzymes back under control. Again, this highlights the need for multidisciplinary and holistic care. Again, not to just manage TB, but manage all the patient's issues. I talked about anchoring bias already in terms of diagnostic delays, and I think Dr. Douglas will also talk about COVID-19 and the impact that has had on the TB program. On a more clinical case, we know that First Nations communities have been disproportionately impacted by COVID-19. Complicating treatment is people who are on rifampin or rifapentine are unable to take nirmatrelvir, ritonavir due to drug interactions. So again, just a little clinical extra risk that patients face when they have TB and COVID co-infection. In terms of contacts, we did identify quite a few contacts, again, overlapping with multiple exposure. Most people are very open to continue with TB preventative therapy. And then what I'd like to highlight is in the region, we've had significant success with the 3-HP, the rifampicin isoniazid. This has been luckily accessible to us since 2019. And it's often created a policy of its use just prior to Public Health Ontario's policy being published around the same time. We were able to designate a regional pharmacy and educate the community nurses by the TB team, and have been able to report huge successes for 3-HP. I probably only have 2 or 3 patients who are unable to complete 3-HP. It is much preferred over 4 months of rifampin, and now 9 months of isoniazid is no longer first line. But again, this has been a game changer for us in the region. It is less onerous for most people to take once a week. People are more mobile. It ensures also regular access to healthcare facility with comprehensive care and multidisciplinary care that could be used as a health intervention. The only drawback, again, nursing education on staff needs to be ongoing due to high turnover of staff in the region. So I'd like to close with some of the opportunities. Despite the challenges, it is an incredible privilege to work with patients, and every time they surprise me about their resilience and their willingness to go through the treatments. I think there's tremendous opportunities to continue to build trust and support between patients, communities, and healthcare providers. And teach people that TB is preventable and curable in most cases, and that there are successes despite all these challenges. I would say that our program is incredibly successful to date. In terms of recommendations to improve the health systems, it is really what I would like to see in the future is moving away from relying on individual people to make it work. Currently, I'm the only ID physician. There's maybe only 1 or 2 TB nurses who can help manage DOT in a region that covers the size of France. So again, creating care pathways, working with the organizations, and having clear pathways in terms of communications and resources so as not to burn out individual resiliency. And that requires ongoing educations, building local capacity, and advocating for equity in healthcare service delivery. So we'll bring it back to Andrea to conclude my section.
Thank you, Dr. Schreiber. It is now our distinct pleasure to welcome a special guest for this next section of the presentation. I'd like to introduce Ms. Joan Ray. Joan is a health director for Sandy Lake First Nation and has worked in the healthcare field for many years. Her goal has been for her home community to have access to the best healthcare and to lead happy, active, and healthy lives. So please welcome Ms. Ray, and look forward to sharing your experiences.
Good morning, everybody, and thank you for inviting me to this session here. So I just want to say some of the experience that we had with having challenges in TB management in my remote northern community of Sandy Lake First Nation. And one of the areas, I'm just going to go down a list of what we did. So the first thing was the testing, and it's always hard getting people to come in to do tests in Sandy Lake. So we had a difficult time having people come for even to read the tests, their TB skin tests. And also the other one was getting sputum samples for testing and having them bring back the sputums to be sent to laboratories out of town. And also there's delays in sending samples out of the community due to planes and also weather. And this also involves delay in getting results of the tests. And then it involves delay in getting treatment if they require treatment. And the other one is contact tracing. And it involves our local health workers. They know how to get people to come in, and they know where people live. And the work is done by local health workers and getting people to come in. And it was the nurse that interviews the clients that come in, and they give the list to the community health workers. And this is done either telephone, cell phone, Facebook, text messages. And as you know, not everybody has a phone, so they do home visits to the clients' houses to get them to come in. And then if all else fails, we usually go see the chief and council to help us to get the people to come in, and the ones that keep avoiding us. And the other one is clinic visits. So we have to find transportation for the clients to come to the clinic because our patient transportation driver is busy as it is. So we hired another driver, a dedicated driver, and we'll have these clients come to the clinic as either contacts or if they're accessing treatment. And plus we needed a dedicated vehicles for transportation for them to come to the clinic for follow-ups, and also it involves gas, and it could be we don't have enough resources, limited for these for the TB management we had. So that was one of the challenges we had. And the other one was accessing treatment and follow-up. So with the clients, we're always advocating for dedicated nurses to do the treatment in the community, and also following up the clients for TB as per physician orders, and keeping track of clients. And this involves hiring local health workers, and we hired 2 people to assist the nurses with the clients, so that way they come here on a timely basis. And also we required a dedicated area in the nursing station for clients to access treatment instead of waiting in our waiting room. So we converted our COVID assessment room into a TB treatment room. So that's where they're doing the TB treatment and follow-ups. Just a little security office with the access to a door. So that way it reduces the time for patients to come and get seen. And we're always short-staffed here, but we have dedicated nurses to do a TB treatment. And that's from ISC, and that's advocating for them, for the nurses to come here to do just the TB clients. And the other challenge we faced was isolation space. When you have a positive patient that comes home with TB and they're contagious, we need to put them in an isolated area. And again, we have limited housing and units even for our people. And to top it off with a positive TB patient. So we did advocate, and we did get a place for one of our clients with the help of our chief and counsel. And so with all these challenges we faced in my community, the outcome was actually pretty good. With everybody working together, we contained the TB in our community, and we survived the challenges of TB management in our remote community. We advocated for patients to receive appropriate treatment, and we advocated for extra personnel from either through the ISC, and when I reached out to SLEPNA to assist us too in our TB management. And also the community leadership, they're a huge help in assisting managing our TB in the community with some difficult patients we had. And I'm happy to say, I think we have contained the TB in the community, and it's all a huge thanks to all people involved in working as a team. That's the physicians, nurses, Minneapolis Hospital, and community leadership, SLEPNA, ISC, and other local health workers. And we have some good local health workers here that do a lot of work to keep our community healthy. Thank you.
Thank you so much, Joan. And just really, really happy to have you here with us and to hear, your experiences from the way you see it. And by the way, this recent cluster is not the first that Joan has kind of experienced and lived through. I think this is like probably Joan's second big cluster, in Sandy Lake. Am I right, Joan?
Yeah, it's about the second one.
Okay, so thanks for being here, and thank you for all your hard work. So as we continue with the presentation, I'm going to close this out now. You can hear from Joan, you hear from Yoko some of the challenges that are on the ground, and we know the historical relationship between TB and, the past, and a lot of what we're seeing at the community level, the underlying social determinants of health, or the lack thereof, this cluster is definitely linked to, poor housing, overcrowded housing, poverty, constant stress. All these issues help to, as I showed you in a graph, all the LTBI, there's a chance for reactivation, and once you have an active case, and especially throughout COVID, when many of our communities were in lockdown, then you could end up with a cluster of cases. So next slide. Clearly, we see the impacts of many determinants of health, and you heard of some of them: stigma, discrimination and racism, geographic isolation, poor housing conditions, lack of trust in the healthcare system, limited healthcare resources, cultural barriers, limited access to diagnostic tools, delays in diagnosis and treatment, lower TB treatment success rates. Again, with a number of players involved, this is leading to the disparities that we see among First Nations with regards to TB. Next slide. So, some of the challenges, and you've heard some of them, several factors that contribute to the disruption of TB management and prevention efforts and the continuity of care. You heard sometimes there are unclear responsibilities across partners and challenges with coordination. And I can tell you that that gets very, very difficult. When Yoko said sometimes the report comes in, to the health unit, and then the health unit, they have to get in touch with us, then we get in touch with the nurse in charge in the community, and you have to find the physician, and they have to find the client who may be out on the land. So just think about some of the challenges there. We have extremely limited human health resources, especially coming out of COVID. I can tell you that there are critical shortages in terms of HHR at the community level. And just want to thank Chief and Council and all the partners for stepping up, and the advocacy, and for the cluster that Joan talked about, cluster of cases. We have had dedicated healthcare providers, working on the cluster. We have high turnover rates in our communities. You heard about that. People come and go, agency nurses, so forth, so on. We have lack of accessibility to specialized TB care at times. We're grateful for Yoko. However, with regards to pediatric TB, sometimes we have some challenges there, and we're also grateful for our partners over at the Winnipeg Health Sciences Center. But you have to fly sometimes the little ones, and just think about all that goes into getting a family over to Winnipeg. Sometimes we experience challenges with access to the pediatric medication due to the location where we're at, special formulation, and it has to come from Winnipeg all the way through to the community. Never mind administering the medication. We have reporting issues. We have multiple databases. Here at SLIFNA, we're using the Mustimuk information systems, but we also have to send the reports over to the public health units. Clearly, piecemeal and unsustainable funding. Right now, the Preventing Infectious Disease team, we pivoted for COVID-19. And throughout that time, I think we were down to one TB nurse. And I just want to thank the PID team at ACW. One PID nurse who was also sucked into COVID-19, having to keep an eye out for TB across a region the size of France. And you heard about challenges with home isolation and de-isolation. Just imagine if we had those resources at the community level, then we don't have to fly individuals outside of the community. We have cases, even recently in hospital for several months, away from friends, away from family, away from their culture, the food, the land. The challenges there. Next slide. So historically, the TB program at SLIFNA, we had TB nurses, TB educators, administrative assistants. Now we're under a PID team, and we're thinking as a health authority that we want to take on all the diseases of public health significance, but we just have, just limited people in the shop at this time. Right now, only 2 nurses for TB, limited administrative staff. We have lost our TB educators, and usually TB educators would be First Nations individuals who have the language. When individuals, let's say, are outside of the community in Sioux Lookout, the TB educators will kind of like walk with them on their journey and help to provide supports. Again, limited funding. Next slide, moving quickly. COVID-19 and the impact on TB in our region. Sometimes I'm wondering, just kind of thinking, if some of the cases that we're now seeing, the cluster that we're now dealing with, if this is indirectly due to COVID-19. While I think we had over 14,000 cases, 65 hospitalizations, and a few deaths, while we did relatively well, some of the rules at the community level, working with chief and councils across the region, we had, more kind of stringent rules in terms of lockdowns and kind of stay-at-home orders. So think about overcrowded homes, people staying inside for a long time. Could that have led to the situation that we're now seeing? I don't know. Maybe. That's what I think. Diagnostic delays and people presenting with more advanced disease, again, diversion of resources and staff. The shift to virtual care would have impacted kind of TB management. And the list goes on and on. Challenges, throughout COVID with regards to active case finding and contact tracing. COVID-19 impacted all of that. But I can really say that, COVID-19 really pulled the resources away from TB management. And TB management, I'm told by one of my most experienced nurse who has been at this program for a long time, that you just have to stay on top of it. Don't really pull people away from TB. Once you reduce the resources for TB management, boom, it pops up, it explodes. Next slide. So innovations in TB care, you heard from Yoko in terms of kind of 3HP for LTBI. I think in the region, we were kind of like one of the first in the province to be doing this kind of work. At that time, it was Dr. Natalie Walkin who led this. She's a public health physician as well, including chief and council in the circle of care. I can tell you that's very, very important. Just keeping, chief and council up to date and having their involvement. And yes, a part of a circle of care or circle of support, call it what you will, they're very helpful in sometimes helping to track down individuals. Telemedicine, virtual rounds for case management, all those are things that have helped us along the way. Next slide. Innovations, providing culturally safe care. I can tell you, you heard from Ray, just having the community health workers involved is so important. Having our nurses who understand the lay of the land is very important. Point of care testing is something that we're hoping that we can bring on board. Happy to know that at Mina Yawin, we have the gene expert that can do PCR, but because of COVID, many communities across the region have been blessed or gifted with, the gene expert device. How can we implement PCR testing at the community level when needed? We also, throughout this cluster, had the opportunity to have an ISC epidemiologist in the field to consult with nurses. That was great. The integration of also the paramedics and community health workers, that was great. Some takeaway points as I try to wrap this up real quick. So we must continue to advocate to sustain community-driven TB elimination strategies that incorporate First Nations principles of wellness, healing, and self-determination. The Approaches to Community Wellbeing model is a very good model for that. Hoping that we could develop a Sioux Lookout Area First Nations TB elimination framework similar to that of ITK. We have to address TB as a socio-political issue and advocate for the elimination of health inequities. We need improved housing in our communities. We need to strengthen community TB services. Joan Ray talked about, funding and the lack thereof. It's not just DOT workers, but it's also transportation and many other things, providing sometimes food for clients who are in isolation. Taking that integrated trauma-informed care approach, strengthen the partnership and collaboration. You can see how many partners that we have across the sectors, and Dr. Yoko talked about, those care pathways. We need to continue to work on those. Consider the importance of social supports. I can tell you it's very difficult to see someone far away from home and you just see them struggling from a mental health perspective, having to be in the hospital sometimes, 2 months, 3 months. And the use of TB treatment as an opportunity to address other health concerns and integrate with other health services. I think we have an opportunity to take this kind of approach that we've taken for TB management and address other issues. So last slide is my thank you slide. There are so many people to thank. So that slide that I showed you with all the partners, I want to thank all the partners. I want to thank Joan Ray. I want to thank the PID team and the hardworking nurses at SLIFNA. I want to thank Yoko. I think Yoko has been a lifesaver. And by the way, she didn't mention, kind of right now, Yoko is like possibly the only ID specialist in Northwestern Ontario. And she's splitting her time sometimes between Northwestern Ontario and Winnipeg. So ID specialists on the call, I think you should probably consider coming to the north to do some work. And I want to thank my team who helped put this slide deck together, and thank PHO for giving us this opportunity. And of course, thanking all the communities and individuals from our communities that they have their lived experiences. Again, we're talking about TB, but remember, TB does impact people. We're talking about real people, real communities. And just a reminder that a lot of the history that some people in other jurisdictions think is historical is still present in our region. Thank you, and I'll stop there. Over to you, Andrea.
Thank you very much, Dr. Douglas and Dr. Schreiber and Ms. Ray, for providing such a comprehensive and illuminating presentation on the challenges of TB prevention and care in Northwestern Ontario. It was much appreciated. We will now use the remaining time we have to address some of the questions that our participants have asked. If you had not yet had the opportunity to enter your question, please do so now. You can do that in the Q&A pod at the bottom right-hand corner of your screen. So we have had a couple of questions so far. So I think this one would be for both Dr. Schreiber and Dr. Douglas. You highlighted in the case descriptions some of the continuing lack of healthcare equity for Indigenous individuals, as well as some of the challenges with the turnover and staffing related to lack of knowledge around specific healthcare issues relating to Indigenous peoples, particularly around TB. And the question is, what is the learning pathway for ensuring cultural awareness and safety for those practitioners who are coming to care for First Nations people in your health area?
I can answer that. For physicians, typically when they're contracted physicians to the region, they will undergo a 2-day cultural safety workshop or learning course. We also recommend that physicians typically do the Sanyas course that is available, has been available for many years. That's in terms of for culturally safe care. In terms of with the specific case of the 50-pound weight loss, I think if you look at it from a patient perspective, in terms of misdiagnosis, missed opportunity, as a patient, sometimes pregnant patients or any patients don't present to the nursing station. That could be due to competing demands, also to past experience, sometimes negative experience at the nursing stations. So patients may not present necessarily to seek care. The other part is in terms of physicians. Most communities, physicians are present in Sandy Lake almost regularly, but often at a 1-week interval. But some communities only have a physician 1 week a month. We try in the region to have the same physician go to the community, so there's a relationship, but due to the lack of physicians in the region in general, both in Sioux Lookout and in the SLIFNA region, sometimes it's a new locum that comes up and it's a first visit to community, and we try to educate people as they come of what you need to know. But again, there's so much to know that TB isn't always on the forefront of people's mind. When people have worked here for several months or years, then they realize what is sort of common, in like TB, blastomycosis is another infectious disease that often gets forgotten unless you've known this region quite well. I hope this answers the question.
Thanks, that was very helpful. I believe this question will also be for Dr. Schreiber. Since the Canadian TB standards were released last year in 2022, have the updated guidelines around de-isolation made any difference on prolonged hospitalizations for those that have to be hospitalized outside of their communities?
Yes and no. I think this is something that's a work in progress. We've been looking at the new TB standards and trying to see how they can be implemented. Some of it is not quite crystal clear on how that would impact a de-isolation at the community level, where housing and is still a big issue. Often people cannot, they have been on treatment maybe for a couple of weeks. They may still be AFB positive, but then with one case, for example, with a TB in Paima, who was definitely infectious for a long time in terms of culture positive and AFB positive for months. Having someone go home to not have stable housing, going in and out of households and not being able to wear masks and maybe not necessarily adhering to some of the DOT still adds additional concerns that I think when we can't just look at isolation in its own, we have to look at the reality of other factors in the community. So this is not a clear answer, but we're looking into ways of incorporating and changing the policy surrounding that. But again, this also requires engagement of the community and chief and council and making sure everybody's on board with the plan forward.
Thank you very much. Our next question is related to some of the challenges that Dr. Douglas spoke to particularly around social determinants of health. And as you mentioned, there are several agencies that are involved in responding to TB prevention and care in your communities. Has there been any successes with broader agencies that address social determinants of health that have been integrated into your TB response?
So that's a very good question, and thank you for that question. So I'm going to take a very upstream approach. And I think we need to go back to as far back as all agencies, all parties, all governments, taking an approach not through rhetoric, but respecting First Nations self-determination and self-governance is going to be the first place to start. I think some of the issues that we're seeing and that we're still dealing with, and for many, many decades, and the progress is so slow, is because there is kind of a lack of action on respecting First Nations self-determination. And what does that look like? So I was listening to an elder about 2 weeks ago, a 77-year-old gentleman who is a lawyer, First Nations lawyer, and he said, respecting First Nations self-determination looks like respecting First Nations jurisdiction, honoring the fact that First Nations do have wealth from the land, honoring the fact that if they do have wealth from the land, then they can build capacity within their communities and have their own systems. So I think that given that TB is a social disease, we need also a solution that does respect, First Nations having jurisdiction over their own lands. And then from that, you can have the economic development. And from the economic development, just think of a day when First Nations would have the resources to build their communities, the homes that they would want, and they're getting rid of overcrowding themselves, they're getting rid of poverty themselves, that sort of a thing. And I think that when the 5 men from Sandy Lake, did that hunger strike for 2 days, that was what they were kind of talking about. And as I've said before, SLIFN as an organization, those 2 principles of respecting self-determination, self-governance is key. So I'm hoping that we can continue the conversation with governments, with the various agencies and partners and other funders to talk about what does First Nations self-determination in public health looks like. What is that? And I think if we start answering that question in a good way, then that's how we're going to start addressing the underlying social determinants of health and start addressing the social disease aspect of TB. I'm hoping that provides that's how I see it in my head, at least.
That was fantastic. Thank you. And I think the next question is somewhat along those lines. You've highlighted a number of challenges and a number of priorities for improving TB prevention and care in First Nations communities. How can we in the health and public health sphere, how can we best help to advocate for some of the solutions that you've proposed? Or how can we work better together to ensure that these solutions are being implemented?
Yoki, do you want to take that one, or do you want to take that one? Or we have Joan on the line as well. Joan could probably chime in. But Yoko, seeing that I just went, all right, she's saying no. All right, how can we work together? I think that, for example, we have a public health model called Approaches to Community Wellbeing. One of the things that we can do is for the policymakers, the decision makers, to one, legally recognize, legal recognition of approaches to community well-being as a First Nations governed and based public health system is one way in which we can work together in order to start addressing some of the underlying issues. So that's one. And also, real commitments. So for example, when Joan is saying something as simple as, gas is expensive in Sandy Lake, and sometimes my budget does not extend to provide, gas for the vehicles that will transport the clients from their homes to the clinic. And just recognizing that we need not piecemeal, fragmented funding. We need streamlined, equitable, consistent, long-term funding. And, funds to kind of look at the big picture, not just looking at care through the nursing station. So we talk about isolation. I'd like to see every community having facilities within their communities as an interim solution until we get better homes. Communities should have isolation facilities. We did it for COVID-19. And I think, for TB, communities, we should get some funding for communities that could have, these units. So, the clients that have to come down and spend long months away from home, that they don't have to go through that. And we recently experienced, I think 2 of our clients recently experienced that from 2 different communities. So, just kind of coming together and just really listening to First Nations, listening to individuals like Joan, and Joan kind of highlighting, I need this, and I need this, and coming alongside the communities and providing those resources, I think are some interim steps until we address, some of the higher level long-term measures that I talked about: jurisdiction, wealth, capacity, and systems.
I just want to add to what Lloyd was saying in terms of, when we address these higher up health inequities and when we build capacity and infrastructure and improve housing, I mean, TB is very close to my heart, but I think we also have to keep in mind that a lot of these improvements will improve the health on so many other levels as well. We struggle with syphilis, we struggle with other infectious diseases, with like unintended drug harms from substance use disorders, and chronic diseases like diabetes. So I think it's just to keep in mind, TB is big, but I think addressing these health inequities will have a much bigger health impact.
Thank you so much for that. And then I think we're just about out of time, so I don't think we will be able to address any more questions at this time. So as we wrap up today's PHO rounds, I would like to extend a very special thank you to our presenters, Dr. Lloyd Douglas, Dr. Yoko Schreiber, and Joan Ray, for sharing with us their extensive knowledge and experience in prevention and care of TB patients in Northwestern Ontario. I would also like to thank all of our online participants today for taking the time to join us. And you can expect to receive a brief and anonymous PHO survey for today's session. So please try to complete this to help us improve our future programming. And lastly, to access past PHO rounds and view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. So thank you again, everyone, and enjoy the rest of your day.